Typhoid fever, caused by salmonella typhi, is a common clinical presentation in OPD settings. This infectious disease is particularly prevalent in areas with limited access to clean water and sanitation. The primary challenges for physicians are accurate diagnosis and appropriate antibiotic management. Typhoid fever spreads through contaminated food and water or close contact with an infected person. Understanding typhoid fever is crucial for effective prevention and treatment. This essay will delve into the intricacies of this disease, covering its symptoms, diagnosis, management, and prevention. Join me as we explore this global health challenge and empower ourselves with knowledge. Typhoid fever often announces itself with a high fever, often exceeding 103 degrees Fahrenheit or 39 degrees Celsius. This fever typically follows a characteristic pattern, rising gradually over several days. This is often referred to as stepladder fever, reflecting its incremental increase. On day 1, the fever may be around 99 degrees Fahrenheit and remains constant. By day 2, it can rise to 100 degrees Fahrenheit and continues to increase daily. Alongside the fever, individuals may experience headaches, which occur in 80% of patients, muscle aches and abdominal pain or distension. Loss of appetite is common, and patients may also experience constipation or pea soup diarrhea, which is green and foul-smelling due to reduced bile absorption. Cough is present in 30% of cases. Early recognition of these symptoms is crucial for prompt medical attention. In addition to the common symptoms, certain clinical signs can aid in diagnosing typhoid fever. One such sign is relative bradycardia, where the pulse does not rise proportionally with the fever. Normally, the pulse increases by about 10 beats per minute for every 1 degree Fahrenheit rise in temperature, but in typhoid fever it only increases by around 5 beats per minute. Another sign is the dicrotic pulse, where 2 palpable impulses are felt, one systolic and one diastolic. Rose spots, which appear in the second week, are small pink blanching spots that may appear on the trunk and extremities. These spots represent bacterial emboli and are culture positive, but they are less visible in dark-skinned patients. Hepatosplenomegaly, or the enlargement of the liver and spleen, is another sign that typically appears in the second week. A thorough physical examination is essential to identify these clinical clues. Laboratory tests play a pivotal role in confirming the diagnosis of typhoid fever. The gold standard for diagnosis is blood culture, where a blood sample is tested for the presence of salmonella typhi. Blood cultures are positive from day 1 but may be negative if antibiotics were taken prior. Another valuable test is the typhoid IgM test, which detects specific antibodies produced by the body in response to the infection. This test is more reliable, becoming positive by day 3 and remaining positive for up to 4 weeks. These tests, along with a detailed medical history and physical examination, help healthcare professionals reach an accurate diagnosis. Additional lab investigations include CBC showing leukopenia and eosinopenia, and elevated SGPT-SGOT in LFTs. Early diagnosis is essential for initiating appropriate treatment and preventing complications such as intestinal bleeding or perforation, which typically occur in the 3rd to 4th week of the illness. Section 5. Diagnosis, connecting the dots. Diagnosing typhoid fever involves a comprehensive evaluation of the patient's symptoms, clinical signs, and laboratory findings. A confirmed diagnosis of typhoid fever requires a fever above 38 degrees Celsius for 3 or more days, and a positive culture from blood, bone marrow, or rose spots. In resource-limited settings, a clinical diagnosis can be made based on high-grade fever, loose stools, coated tongue, and relative bradycardia, which has a 94% specificity. The World Health Organization, or WHO, provides guidelines for diagnosing typhoid fever, emphasizing the importance of considering both clinical and laboratory data. Accurate diagnosis is crucial for guiding treatment decisions and implementing public health measures. Section 6. Managing Uncomplicated Typhoid, a Step-by-Step Guide. The mainstay of treatment for uncomplicated typhoid fever is antibiotic therapy. First-line options include fluoroquinolones such as ofloxacin 400 mg BD or third-generation cephalosporins like Cefixime 400 mg BD. These medications work by killing the bacteria, thus clearing the infection. In addition to antibiotics, supportive care is essential. This includes rest, adequate fluid intake, and a nutritious diet. Response assessment should be done on day 5. If the patient is responsive, continue the antibiotic for 5 more days, totaling 10 days. If there is no response, add cefixime if on afloxacin, or afloxacin if on cefixime. Reassess at day 10. If still unresponsive, add azithromycin for 5 days. Close monitoring of the patient's condition is crucial to ensure a successful recovery. Section 7. Tackling complications. When typhoid takes a turn. While most cases of typhoid fever are uncomplicated, complications can arise. These complications can affect various organ systems, including the central nervous system, cardiovascular system, and respiratory system. Meningitis, encephalitis, myocarditis, and pneumonia are some potential complications. Managing complicated typhoid requires specialized care and often involves hospitalization. Intravenous antibiotics, fluid resuscitation, and other supportive measures are crucial for addressing these complications and preventing long-term sequelae. For complicated typhoid involving the CNS, CVS, or respiratory system, IV ceftriaxone, 2-GBD, or cefotaxime, 80 mg/kg/day, for 2 weeks is recommended. In severe cases, steroids like dexamethasone, 3 mg per kilogram stat, then 1 mg per kilogram Q6H for 8 doses may be used. For extensively drug-resistant XDR, typhoid meropenem, 1G TDS for 10-14 days, is the treatment of choice. Note that first and second generation cephalosporins and aminoglycosides are ineffective against XDR typhoid. Section 8. Understanding the carrier state. The carrier state in typhoid fever refers to individuals who are asymptomatic but have stool cultures positive for the bacteria. There are 2 types of carriers: temporary and chronic. Temporary carriers shed the bacteria for 3 weeks to 1 year. Chronic carriers shed the bacteria for more than 1 year and require treatment to prevent the spread. Treatment for chronic carriers includes ciprofloxacin, 750 mg twice daily for 4 weeks. In cases where gallbladder stones are present, a cholecystectomy may be necessary. This helps to eliminate the carrier state and prevent further transmission of the disease. International collaboration is crucial to manage and treat carriers effectively. Section 9. Key takeaways for typhoid fever management. Prioritize blood culture and typhoid IgM test over the Whittle test for accurate diagnosis. Clinical signs such as fever, bradycardia, coated tongue, and diarrhea are highly specific in resource-limited settings. Antibiotic response typically takes around 5 days, so avoid changing the regimen too early. Remember, breaking the chain of transmission is crucial for controlling typhoid fever. This includes access to clean water and sanitation, safe food handling practices, and vaccination. Identifying and treating carriers is essential for controlling the spread of typhoid fever. Individuals who recover from typhoid fever can continue to harbor the bacteria in their gallbladder, shedding them in their feces, and potentially infecting others.